Hello to all my lovely friends. I am Dr. Arun Swami, your physiology faculty. एग्जाम इज ओवर। तो बेटा अब कोई टेंशन दिमाग में नहीं रखनी है। पेपर कैसा हुआ है कैसा नहीं हुआ है, नो नीड टू बी पैनिक। एवरीथिंग इज नाउ सबमिटेड। दिस इज द टाइम व्हेन यू शुड शेयर दिस टाइम with your friends, with family and with your loved ones, because from past several months you fight it very hard and obviously this is the time to relax. Okay, तो अब जैसा भी पेपर हुआ है जस्ट रिलैक्स और अपना अच्छे से ये टाइम निकालो बेटा, क्योंकि you all are warriors and definitely result will be also will be the positive side, so no need to be worry about the result and all. Let's talking about the recall session for the physiology. This recall session is basically based on the questions which told by the students, and those questions is actually I framed in the same scenario. That's how the student told me, right? So let's discuss about this recall session. First of all, the paper analysis. In the paper analysis, as per that, lot of the students जो सबने मेरे को बताया guys, the paper was the moderate type. Paper 1 was little bit tricky but moderate level, and the second paper that most of the student told me sir easy, and but the questions were very much lengthy. बहुत बड़े बड़े क्वेश्चन दिए थे सर, टाइम मैनेजमेंट नहीं हो पा रहा था. सो एक्चुअली दैट जब बड़े क्वेश्चंस होते हैं तो वी वर गेटिंग डिफिकल्टी टू read all the questions properly, and definitely the time is running out. So that second paper was easy but lengthy. Overall the paper was moderate. In this paper from the physiology approx 20 MCQ is asked. Out of that, all of the most of the MCQs they asked directly from the physiology workbook which we studied during this several months, right? And the most favorite topic from the physio this time by the examiner, I don't know beta ऐसा क्यों हुआ है क्या हुआ है, but the most favorite topic definitely you all know that is ABG. और ABG के तो पहले पेपर में भी सवाल थे, दूसरे पेपर में भी सवाल थे, और ABG को अपन ने जिस तरीके से पढ़ा था बेटा, definitely it helped a lot. I hope that all you enjoyed this ABG analysis MCQs during your paper time, right? So let's discuss about the first question which asks, guys, the one thing I would like to let you know, if any of the questions which is not asked in this examination like ways I'm telling you, तो बेटा आप मेरे को please in the comment section you can let me know that sir what was the exact question or exact option for that, because I tried hard to make or to form these MCQs in the same way like they ask in the examination. Okay, so let's talking about the first question. This was the question which asked, the same picture is asked as student told me that yes sir ki same picture I think. So the question was in the following left ventricular pressure volume loop, the points A B C D, the points A B C D is mentioned. So this was the point A, this was the point A, this was B, this was C, and this was D. This is the picture which ask in your examination, and examiner is already telling that where the aortic wall is going to be open, right? So at which point the aortic wall is going to be open. So as we know, the aortic wall will be open at point number C, right? So A is for mitral opening, B is for mitral closing, C is for aortic opening, and D is for aortic closing. So this is the pressure volume curve from the left ventricle. So right answer of this question was option number C, right? Option number C. Okay. So this is the image which we discussed in the video session in the YouTube channel. So the same question is asked in your examination. Okay. So as we can see that there, this is your aortic wall opening at point C. Okay. Coming to the next question. As per the student told me, sir, handwritten image was there for the type of breathing, and this type of image was given. So guys, if this type of image was given and asking the breathing pattern type, guys, the right answer of this question should be, this should be the option number C, that is Cheney-Stokes breathing, because this is a type of a crescendo decrescendo type of a breathing, right guys? And there is a apnea followed by the apnea. So this is the Cheney-Stokes type of breathing. कुछ स्टूडेंट्स ने मेरे को बताया है कि नहीं सर इस टाइप की नहीं थी, बायोट्स ब्रीदिंग की थी। तो गाइस इफ द बायोट्स ब्रीदिंग वर देयर, सो दिस शुड बी लाइक दिस, दिस इज नॉट द क्रिसेंडो डिक्रिसेंडो टाइप लाइक दिस। So there is no absolutely pattern is there, everything looking like abnormal condition, कोई भी वहाँ पैटर्न प्रॉपर्ली नहीं दिखता है, सब कुछ आपको इधर उधर दिखता है। सो दैट इज योर बायोट्स ब्रीदिंग। सो इफ इमेज वाज गिवन दिस टाइप क्रिसेंडो डिक्रिसेंडो टाइप, आंसर शुड बी Cheney's talks, but if it is given in like this manner like this, anything, that is your biot's breathing. Okay, so it depends which type of image was asked in your examination, right? So these the different type of breathing pattern we discussed during the classes. So all these are Cheney's talks, biot's, Kussmaul, and the apneustic. Kussmaul is tachypnea and bradypnea, means faster and deeper breathing, right? Now the next question is, a 30-year-old man is brought to the emergency room after a road traffic accident with the head injury. Over the next 1 hour, he becomes drowsy. Vital shows BP was high, BP was 200 to 110, heart rate was less, right? And the sign suggestive of increased intracranial pressure. Question asked, which reflex is that? So guys, we know if your heart rate is less, BP is high, and intracranial pressure is high, and irregular respiration is also there. So guys, this is your Cushing reflex. This is our Cushing reflex. Okay, so right answer on this question was Cushing reflex. So different type of reflexes, you should know that these which we discussed during the classes. So guys, in the Cushing reflex we discuss high intracranial pressure, hypertension, and bradycardia, right? So this is your Cushing reflex. In vein bridge, increased venous return leading to tachycardia. Bajol-Jaris reflex seen in left ventricular condition like MI and decrease the preload, right? So this is lead to the paradoxical bradycardia and hypotension, right? And in CNS ischemic response, when the brain is not able to get the sufficient blood, guys, what will be happening? This will lead to the severe hypertension, right? And usually heart rate is decreased, right? Heart rate will be decreased by the baroreceptor reflex. Okay, so these are the different reflexes. The next question was, during the bladder filling, intravesical pressure rises very little despite a large increase in volume. This phenomena is best explained by the Laplace law. So Laplace law was given in the MCQ and normal bladder physiology. Which of the following statement is most correct? Guys, this type of image was given from the cystometrogram and Laplace law was mentioned in the MCQ, right? तो अगर बेटा ऐसा था, if the Laplace law was mentioned in the MCQ and this image was given and option were asking like this about the sympathetic and parasympathetic. So guys, in this the options, if you will see that this is your phase 1, this is 2, this is 3, right? So this is your cystometrogram and the question is asking about this phase, which is called as a Laplace law, right? Laplace law due to the plasticity. Okay, and guys, we know that urinary bladder is containing the detrusor muscle. So detrusor muscle is present into the urinary bladder, which is actually a type of a smooth muscle, and we know that all smooth muscle is connected via the autonomic nervous system, and this autonomic nervous system is divided into two, sympathetic and parasympathetic. Guys, remember during the classes I told you how the urine is coming out when you are fully relaxed, and immediately if you are in stress, if you are in fear, guys, sympathetic activation lead to stoppage of the urine, right? So this was happening, we have done this part in during the classes. So guys, we know the sympathetic is always decrease the urine output and parasympathetic always increase the urine output, right? So guys, sympathetic is not going to lead the detrusor muscle contraction, it always prevent, because if this is the urinary bladder, if muscle gets contract, urine start coming out. So this muscle should not be contract, and guys, this was the option was given, the sympathetic stimulation prevents the detrusor muscle contract. So this was the right answer of this question, right? So if this type of options were given, out of that, right answer was the sympathetic stimulation prevent the detrusor muscle contraction, right? So this is, we know that sympathetic store the urine, parasympathetic void the urine via detrusor muscle contraction and sphincter relax due to the parasympathetic stimulation. And the sympathetic it doing the retrocessor relax and the sphincter will be contract. That is, we're talking about the internal sphincter. And this is the phase 2, which is the accommodation phase. And guys, during this time there is a Laplace law which stands for pressure is equal to 2T upon R, right? T is tension, R is radius, and this prevents basically the early urge and it protects the kidney from the back pressure, right? And that's why we are able to hold the urine in a larger volume, right? Okay, coming to the next question. The next question was from the ABG. Guys, from the ABG, almost 4 questions were asked. Some student told me, sir, 5 questions were there. Some students told me, no, sir, 4 questions were there. So, guys, the question was, a 6-year-old child has a watery diarrhea from the 2 days, 5 to 6 episodes per day. ABG showed decreased PaCO2. Which of the following finding is the most likely true? Guys, this type of options were given. Sir, pH ज़्यादा था बाइकार्बोनेट का CO2 का क्लोराइड का बना के कुछ इस तरीके से उन्होंने एक सीक्वेंस दी थी एंड वी हैव टू आइडेंटिफाई द मोस्ट लाइकली और द ट्रू स्टेटमेंट राइट और द ट्रू कंडीशन. सो गाइस वी नो इफ द डायरिया इज देयर, if diarrhea is there, guys, this diarrhea lead to what? The diarrhea always lead to metabolic acidosis. Metabolic acidosis, we know that, right? So diarrhea lead to metabolic acidosis. Okay, and it also leads to hypokalemia. Hypokalemia, right? The two condition happens in the diarrhea. So guys, now you can easily see that if diarrhea causes metabolic acidosis because there is a loss of alkaline part from the diarrhea, and guys, what will be happening if acidosis is there? Guys, pH should be less than 7.35. Bicarbonate should be, because metabolic, so bicarbonate also should be less, right? And in this, if the bicarbonate is less and pH is less, body is going towards the acidic part. Guys, body will try to compensate, and it compensating via the CO2. So guys, CO2 washout will be there because CO2 is acidic gas, so CO2 will be also less due to the washout condition, right? So you can see this will be the scenario will be seen in the watery diarrhea condition. And here you can see in option B, the pH is less, bicarbonate is less, CO2 is less, right guys? And even if you don't know about the chloride, what is happening, guys, with this part you can easily identify the right answer, right? So chloride as a compensation basically increased. Okay, now, so this was the right answer of this question. So we discussed about this part. In the metabolic acidosis, pH is decreased and bicarbonate is decreased and CO2 is always compensate. In metabolic alkalosis, pH increase, bicarbonate increase and CO2 compensate. If the respiratory acidosis will talk about pH decrease and CO2 decrease and metabolic bicarbonate is always compensate. And in respiratory alkalosis, pH will be increase and CO2 will be decrease and bicarbonate will be compensate. So we know the CO2 is a acidic content and bicarbonate is having always the basic content part or the property, right? Now, coming to the next question. A 28-year-old man develops descending flaccid paralysis, diplopia and the dysphagia after eating improperly canned food. Guys, canned food history was given that स्टूडेंट ने ऐसा कुछ मेरे को बताया था. एंड इन द अनदर पेशेंट डेवलप्स रैपिड पैरालिसिस आफ्टर ईटिंग द पफर फिश, राइट? विच ऑफ द फॉलोइंग करेक्टली मैचेस द मैकेनिज्म ऑफ एक्शन? तो यहाँ पे दो चीजों का मैकेनिज्म ऑफ एक्शन दे वर आस्किंग. नंबर वन, दे आर आस्किंग फ्रॉम द improperly canned food, and guys, we know that improperly canned food it is the main cause for the botulinum toxin, right? So it is a history or which is given by the botulinum toxin. And guys, in the puffer fish, the main toxin which happens, that is your tetrodotoxin, right? So the two toxins is basically were given via in a different manner, and you have to identify what is the mechanism of action. And guys, in classes many times I told you the mechanism of action of the botulinum toxin. Guys, botulinum toxin basically prevents the acetylcholine release from the presynaptic areas via blocking the snare protein, right? So even if you don't know What was the mechanism of tetrodotoxin, guys? Guys, you can easily identify it via the botulinum toxin. And many of the students told me कि सर हमारे को दूसरा वाला तो नहीं पता था, लेकिन botulinum toxin का हमारे को mechanism of action we were very well remembered, guys, sir. So basically from this part we mark the answer. So guys, no need to worry. इसी तरीके से sometimes if you'll stuck in any MCQs, you can identify via the rule out method, right? Okay. So right answer of this question was botulism B, that is botulinum toxin prevents the acetylcholine release via the cleavage of snare protein, and tetrodotoxin blocks the voltage gated sodium channel. Guys, what is the mechanism of the tetrodotoxin? We know that this is the canned food. In the canned food, this is basically the source of the botulinum toxin. Normally, we know that if this is the normal presynaptic area, action potential comes, calcium gets entered, and the vesicle getting released via the exocytosis. We know that, and at the postsynaptic area, it increase the action potential via leading the sodium influx. Guys, what happening in the botulinum toxin? Everything happens. Action potential comes, calcium get enters, but this vesicle not able to exit out, and this lead to what? This lead to the paralysis of this postsynaptic area, because no action is going to be happen if the neurotransmitter is not going to be released. So this is the mechanism of action of the botulinum toxin. But if the action potential is coming from the upper side, guys, we know action potential always comes due to the influx of which ion? Sodium influx. And guys, if the sodium channel gets closed at this area, guys, what will be happen? Action potential cannot be generated, and no action potential will be happen over here. And guys, no calcium entry, no process of this mechanism. So this will lead to what? Again, the paralysis condition. Okay. And this is the mechanism of the tetrodotoxin. So this is the puffer fish, which you can see over here. This is your puffer fish, and in the puffer fish, what is happening? This presynaptic area, when the action potential is coming up, sodium cannot able to go inside, and nothing starts at the axon terminal area, and postsynaptic area doesn't receive anything, right, leading to paralysis or the deactivation of the postsynaptic neuron. Okay, so this is the mechanism of action of the tetrodotoxin. Coming to the next question. A 45-year-old man underwent right pneumonectomy. One lung was removed 6 months ago. He is stable now and comes for the pulmonary function evaluation. Which of the following is most likely decrease? तो स्टूडेंट्स ने बोला था कि सर एक लंग रिमूव की हिस्ट्री थी और PFT was done and they were asking about the compliance. And guys, options were given like the chest wall compliance, specific compliance, lung compliance, and this compliance both lung and the chest wall, and they were asking about what is going to be decrease. Guys, the right answer of this question was the total lung compliance will be decrease. Why? Because this removing of the one lung, the total lung tissue is decreased, because only now the one lung is remain in the body. So total lung tissue is decreased, and compliance means the stretchability. So if the tissue itself is decreased, agar tissue hi kam hai, so guys, compliance will be also less, right? So the total lung compliance will be decreased, right? Chest wall compliance will remain normal, because we done nothing with the chest wall. Chest wall is absolutely fine, and the specific compliance, it is usually normal. But because both compliance and the lung volume reduce the proportionally, so this is not the specific compliance, not the chest wall compliance. The right answer of this question was that the total lung compliance will be decreased. Okay, coming to the next question. A 28-year-old woman in her third trimester of pregnancy has the following ABG values. Guys, third trimester was given in the MCQ in the question, and there were some ABG values were given. So this is the recall which actually I got from the student. So I hope this question was framed in the same way. Guys, in the pH, there were mentioned that pH is 7.45. PCO2 was 28 is given, and bicarbonate was 20, right? These were the values were given during the exam, and they were asking what is the most likely acid-base disorder. Guys, in the third trimester pregnancy, progesterone is high, and in the progesterone high condition, there is always and always hyperventilation, right? And guys, if we know if hyperventilation will be happen, guys, CO2 washout will be there. CO2 washout will be there, and if CO2 is washing out, right guys, what the body is going towards? The body will go towards that, body will go towards the alkaline side. So alkalosis will be happening, right? So guys, this is how this already, even if you don't know about the third trimester pregnancy progesterone condition, guys, you can easily see the pH was increased, means this is the alkaline. The CO2 was less, means this is also the alkalosis, right? This is also the alkalosis, this is alkalosis, right? Now bicarbonate is also less, means this is going towards the acidosis side. So who is the culprit? Culprit was the CO2. And guys, if culprit was the CO2, this is the respiratory alkalosis with hyperventilation with metabolic compensation, right? So now you can see the options. The options were given: hyperventilated respiratory alkalosis, yes; metabolic alkalosis, no; metabolic acidosis, no. So these two things is already ruled out, right? Hypoventilated, no. No hypoventilation happens. There is always, and even no respiratory acidosis. This is respiratory alkalosis. So right answer of this question is A, hyperventilated respiratory alkalosis. Coming to the next question, this was the image is given directly from the workbook, and this is a strength duration curve which is shown with the points A, B, C marked. Which of the following is the correct matching, right? And they were mentioned that this is your point A, this is your point B, and this is your point C, right guys? During the classes from the workbook, I already told you that A is Riobase, A is Riobase, C was your Chronaxi, and B was, this is the utilization time. B was the utilization time, right? So you can see over here which is the correct matching. The correct matching was the A was the Riobase, right? So this is your Riobase, C is Chronaxi, and B is utilization time. So right answer of this question is D. Okay, so this is the right answer. So this is the direct image which asked from your workbook, right? And I told you that this is the Chronaxi, that is your Riobase, and this area is your utilization time. Okay, so guys, you can see the Riobase was the minimum strength. Chronaxi, when the Riobase is double, and the utilization time, this is the minimum time for the strength to excite the tissue, right, or the muscle. In strength duration curve, the longer duration will be required the less current, and the shorter duration required the more current. Okay, now coming to the next question. The next question was given for the DKA. From the DKA, right, they gave the history for the DKA, diabetic ketoacidosis, and the question was asked: a 22-year-old female with type 1 diabetes mellitus. Type 1 diabetes mellitus was clearly mentioned, as the student told me, with polyuria, polydipsia, vomiting, abdominal pain, and deep rapid breathing for 1 day. She is dehydrated and had a fruity breath odor. Her random blood glucose is 400. ABG is given, that was 7.30, CO2 was 20, and the bicarbonate was 14, right? And they were asking what is the most likely acid-base disorder. So this was the clear-cut case of the diabetic ketoacidosis, and the word is already saying the person is going towards the acidic side. Why? Due to the ketones, right? Ketones. Okay, so from the ABG values you can easily identify what is the condition. You can see over here the pH is going towards the acid side, CO2 is going towards the alkaline side because CO2 is less, and bicarbonate is going towards the acid side. So who is the culprit? The culprit was bicarbonate. So guys, what was this? This was your metabolic acidosis with respiratory alkalosis as a compensation. So this is the right answer. That was the metabolic acidosis with respiratory compensation, right? Respiratory compensation. And there was given also the high anion gap. Guys, please pay attention. During the classes I told you about the metabolic acidosis, which was two type, hagma and nagma. Guys, I told you कि remember for the one type hagma ko yaad karo, that is alcohol, aspirin, renal failure, and the ketones, right guys? And this ketones means the person is going towards the diabetic ketoacidosis, right? So this was your high anion gap metabolic acidosis. So right answer of this question was the high anion gap metabolic acidosis B, right? Coming to the next question, a direct ABG was given, nothing was mentioned, कुछ भी mention नहीं करा था sir, सीधी value दी थी and they just asked what is the most likely acid base disorder. So the values were given 7.25, that is pH, CO2 was 24, bicarbonate was 12. So guys, please pay attention. 7.25 means acid, CO2 24 means alkaline, and bicarbonate 12 means acid. So guys, what is this? Who is the culprit? You can see the culprit was bicarbonate. So this is metabolic acidosis with respiratory alkalosis as a compensation, right? So the right answer of this question is metabolic acidosis with respiratory compensation, C. Okay. Coming to the next question. The direct question asks, a female is regularly taking iron and folic acid tablet to improve iron absorption. Which additional supplement is most appropriate? Bread and butter question, guys. कोई भी इसको गलत नहीं कर सकता था. The right answer of this question was vitamin C for the conversion of Fe3 plus to Fe2 plus, and then it is going to be absorbed from the intestinal gut, from the apical side, and this transporter we called as DMT1. DMT1. So DMT1 was the transporter which is required for the iron absorption, right? DMT1, divalent metal transporter 1 on the apical wall of intestinal enterocyte, right? So this is the vitamin C. One more question they ask from the vitamin K. So guys, this is the question which asked about the iron and folic acid tablet. Answer was the vitamin C. Then the next question was, a 28-year-old man goes for the hiking at an altitude of 4,000 meters. After a few hours, he developed headache, nausea and vomiting. With dizziness and fatigue, what is the most immediate advice? Guys, question was easy, but it was slightly tricky question. You should use your sense while you are solving such MCQs. Guys, in classes, I told you the mountain sickness, the drug of choice for mountain sickness was the acetazolamide, right? But this is the drug. Guys, remember acetazolamide is the drug of choice for the mountain sickness, and this is basically prevents. So we give as a prevention. But as the person is already on the high mountain area, start having the mountain sickness. And guys, what is the immediate advice? जिस कारण से उसको वो कंडीशन हुई है उसको रिवर्स कर दो, यानी कि ऊपर जाने से उसको तकलीफ हुई थी तो उसको नीचे भेज दो. सो गाइज, व्हाट इज द इमीडिएट एडवाइस? द इमीडिएट एडवाइस वाज द इमीडिएट डिसेंट टू द लोअर एल्टीट्यूड. गाइज, प्लीज पे अटेंशन. Please pay attention that immediate advice were asking. So immediate advice कि जो काम आप कर रहे हो उसको रोको और जो पहले जिस कंडीशन में थे उसी कंडीशन में चले जाओ. So immediately go to the downside at the lower altitude area. Even because if you will give the acetazolamide, it will take some time to show the action. At least half an hour वो अंदर जाएगी, absorb होएगी, उसके बाद में action आएगा. And this is only for the prevention. But already the person is suffering from that condition. So what is the immediate advice? Immediate descent down, right? So this was the right answer of this question. The IV dexamethasone, this give when the HAG is there. This condition is there, means there is a high altitude cerebral edema. So in this condition, when the high altitude cerebral edema, there is a mental confusion, there is dizziness, all this condition is there, we can give the IV dexamethasone, and furosemide is not related with this part, right? So the right answer of this question was C, immediate descent to the lower altitude. So acute mountain sickness, the best immediate treatment was descent plus oxygen. Acetazolamide for the prevention we give, dexamethasone for the severe cases like the high altitude cerebral edema, and furosemide is not the first line. Okay, now coming to the next question. The question is directly asked, but little bit tricky question is there, and a typical nerve action potential graph is shown. At which point will the membrane show the least conductance for both sodium and potassium channel. Guys, question is asking the least conductance, right, for the sodium and potassium. So this nerve action potential we discussed, and I told you that from the minus 70, this was the resting membrane potential of the nerve fiber. It goes towards the upside, right? And this is the area where the sodium influx happens. We called as a depolarization. This is the action potential area, and this is the potassium efflux happens, leading to repolarization, and this is the hyperpolarization area due to the slow closure of the potassium channel. And guys, this is the reestablishment of the polarized state due to sodium potassium pump. So this is the thing we discussed during the classes. Guys, the question is asking the least conductance. Least conductance means when the both channels are closed. When the both channels are closed, during that time there will be the least conductance, and both channels are closed during when? This is always closed during the resting membrane potential. And the resting membrane potential is which point? This is point number A, right? So the A, B, C, D, E, F were given. Guys, if the least conductance they were asking, this happens during the resting membrane potential. So right answer of this question is A. Okay, now, so you should remember that voltage gated sodium and potassium channel is closed at resting membrane potential, right? Guys, the sodium conductance is increased from which point to which point? From B to C, and this potassium conductance increase from this C to E, like this. Okay, so the least conductance is at point number A. Coming to the next question. A man is taking NSAIDs regularly. Due to the gastritis symptoms, he starts a new medication, after which his gastric acid secretion becomes markedly lower. After a few months, he develops fatigue and anemia. The drug is working poorly due to the low gastric acidity, leading to deficiency of which of the following? सो दिस सच टाइप ऑफ लैंग्वेज वर गिवन, एनसेट की हिस्ट्री दी थी और एक ड्रग के बारे में पूछा था कि उसने कुछ काम गड़बड़ करा, और दे वर आस्किंग दैट विच एंजाइम और लीडिंग टू डेफिशिएंसी ऑफ विच सब्सटेंस इज हैपनिंग, राइट? सो राइस द ऑप्शंस वर गिवन सीसीके, गैस्ट्रिन, सिक्रेटिन, इंट्रिंसिक फैक्टर. द राइट आंसर ऑफ दिस क्वेश्चन इज इंट्रिंसिक फैक्टर, because HCl is produced by the oxyntic parietal cell, and guys, this parietal cell is inhibited due to the PPIs, proton pump inhibitors, right? And this intrinsic factor is also produced via the parietal cell. So if PPI inhibit or block the oxyntic parietal cell, the intrinsic factor is also going to be reduced, right? So this leading to deficiency of the intrinsic factor, and we know that this intrinsic factor is required the B12 absorption, right? So guys, please pay attention. The B12 absorption is going to be happen at the terminal ileum, and this is required the Kessel intrinsic factor. If B12 absorption is not going to be happen, this can lead to the anemia we called as a pernicious anemia. So right answer of this question was intrinsic factor. The next question is, a 32-year-old man with nephrogenic diabetes insipidus started on a thiazide diuretic. After a few days, his urine output decreases. However, ABG shows metabolic alkalosis and urine becomes more acidic, which is a paradoxical aciduria. What is the most likely mechanism for this finding? Guys, in this MCQ, I didn't get the proper options which is actually given. So I tried to frame as per the recall basis from the students, and in the options they were given the thiazide causes that volume contraction, increase aldosterone and increase H secretion in the collecting duct. Thiazide inhibit carbonic anhydrase, thiazide directly block H ion ATPase intercalated cell, and thiazide increase ADH action on the V2 receptor. The right answer of this question was B, that thiazide which act on the DCT level via blocking the NaCl channel. Guys, this is always causes the volume contraction. Little bit volume is going to be shrink. What will be happening? Aldosterone will be increased, H will be secrete from the collecting duct, right? Collecting duct, which can lead to the acidic urine, right? Acidic urine. So you can see over here that thiazide, this is leading to ECF depletion. If the ECF is going to be depleted, what will be happening? RAS will be start, volume losing, RAS is start, and RAS will ultimately activate the aldosterone. This aldosterone, what it will do? It will increase the sodium reabsorption at collecting duct. H ion will be secrete more from the intercalated cell, leading to what? Acidic urine and leading to metabolic alkalosis, right? So thiazide diuretic, this is act at the DCT level via blocks which channel, guys? Sodium chloride channel. So right answer of this question was B. Thiazide causes volume contraction, increases aldosterone, increase H secretion in the collecting duct. Question number 17. A 26-year-old man has a persistent hypertension. Lab reports show hypokalemia, but serum sodium is normal. This was clear-cut mentioned. The serum sodium is normal and hypokalemia is there and there is hypertension. There is no edema. So which of the following is most likely cause, right? Option were given: pheochromocytoma, Cone syndrome, Riddle syndrome, renal artery stenosis, right? The right answer of this question was B, that is Cone's syndrome. Guys, please pay attention. The pheochromocytoma, this is related with the catecholamines, epinephrine or epinephrine, and it always causes the vasoconstriction, leading to hypertension, but it doesn't relate with the potassium level. So it does not impact on anything with the potassium, right? So no pheochromocytoma condition is there. Liddles, until unless there is nothing is mentioned related with the renin and aldosterone, guys, riddles we cannot be considered. And renal artery stenosis, this is nothing is mentioned related with the obstruction and anything in the MCQ. So right option which we can go with that is the Cone syndrome. Although in the cone sodium can be increased, but it may be normal. It may be normal, but definitely hypokalemia will be there and hypertension and also the metabolic alkalosis condition will be there, right? So we know the Cone's disease, which is a primary hyperaldosteronism, forms from the collecting duct and late DCT. There is a increased sodium reabsorption, increased potassium loss leading to hypokalemia, hypertension, and H ion loss causes the metabolic alkalosis, right? So aldosterone basically escape, so sodium often can be normal in Cone's disease, right? So this was a little bit tricky part from the MCQ by the examiner, right? Now, the next question, image were given and they were asking that which of the following murmur is most characteristically here. And this type of image was given and they were clearly mentioned that there is a hole in the ventricular septum, and this condition we called as VSD, ventricular septal defect. And guys, we know that in the VSD there is a pansystolic murmur, right? There is a pansystolic murmur. So right answer of this question is pansystolic murmur. Okay, option C. So the different type of murmur, that is the VSD MR, that is showing the pansystolic, which is also called as holosystolic murmur. ASD will show you the ejection systolic or fixed split S2. PDA, continuous murmur or machinery murmur. And the MS, mitral stenosis, that is mid diastolic rumbling. AR will show you the early diastolic decrescendo, and AS will show you the ejection systolic, right? So direct question from that part, from the our workbook, we also discuss about all these murmurs, right? Coming to the next question, this type of ECG were given, one image was given for the normal ECG, another one given for that ST elevation was clearly mentioned, right? So an ECG shows the ST elevation in lead V3 and V4, this was mentioned in the MCQ, and the most probable diagnosis they asked. So guys, this was the bread and butter question. You can see this part was the normal and this was for the MI, right? So you can see over here that this is the ST elevation which is clearly present over here, and this is your acute myocardial infarction, right? Acute myocardial infarction. So the different condition will be happening in the different pathological condition in the ECG. So guys, in ischemia there is a ST depression and T inversion, right? In myocardial infarction there is a ST elevation which is shown in the image. In hyperkalemia there is a tall tented T wave. And guys, in heart block, this is related with the PR abnormality, right? In the first degree, second degree, third degree heart block. So this was shown in the ECG. That is the right answer of this question was MI, myocardial infarction. And the last question, a man is brought to the hospital by his wife. She reports that after a stroke, he is speaking fluently, but his speech is meaningless and irrelevant. MRI shows a lesion in the posterior part of the superior temporal gyrus. Which area is most likely damaged? Guys, bread and butter question, that meaningless speech, posterior superior temporal gyrus. The right answer of this question was Wernicke's area, right? Wernicke's area. So we know that Broca's area is located at left inferior frontal gyrus, and this can lead to the non-fluent speech, right? Motor aphasia. Wernicke's area, this is at the posterior superior temporal gyrus, and this is showing the lesion fluent, meaningless, but sensory aphasia. And angular gyrus, this is presenting into the parietal lobe, and this is for reading, writing, and naming the object, and person cannot able to read anything. We called as a alexia like this, and this will show the Gerstmann syndrome, right? Gerstmann syndrome we discuss in the YouTube videos. So Gerstmann syndrome, right? Arcuate fasciculus, these are the fiber which is making a connection between the Broca's and Wernicke's. So they are going to be lost, can lead to the conduction aphasia, right? So repetition could not be possible by this person. So you will ask something, person will say something, right? So no repetition will be there. So the in MCQs, posterior superior temporal gyrus were given. So right answer of this question was Wernicke's area, right? So guys, many students told me, sir, most of the questions directly from the book, and sir, most of the physiology MCQs were correct. Guys, I'm very happy to all of you for your दिस रेस्पॉन्स फ्रॉम द फिजियोलॉजी, जो एक सब्जेक्ट कभी आप लोग पढ़ते नहीं थे बेटा, आज उस सब्जेक्ट में आप लोग की इतनी अच्छी कमांड है गाइस. सो विश यू ऑल द बेस्ट फॉर योर रिजल्ट and let's enjoy your this time. We are always together. Thank you very much for watching this recall session.